Welcome to this explainer. If you work in healthcare, you know this exact feeling all too well. The monitor is literally blaring, your patient needs meds like yesterday, the family is stirring holes into you, and all that pressure to secure IV access is resting squarely on your shoulders. Today, we're zeroing in on this absolutely critical clinical skill. We are going to unlock a masterclass turning rapid-fire clinical tips into a rock-solid step-by-step procedure for first-pass success in IV cannulation. Whether you're running around a chaotic emergency department or working a quiet ward, mastering this, it's a real game changer for your daily practice. Look, we have all been there. You're at the bedside, the pressure's on, and you miss the IV. It is incredibly frustrating, isn't it? But missing IV cannulas repeatedly doesn't just eat into your precious time. Think about the ripple effect here. It delays life-saving antibiotics, it pushes back critical CT scans, and honestly, it rapidly erodes patient trust when they start feeling like a human pincushion. By applying these evidence-based emergency medicine pearls, you are going to save valuable time, significantly reduce your patient's pain, and ultimately become a much more effective, trusted clinician. Okay, let's dive into this. We're taking a highly structured, chronological approach to patient care today. We've got 4 clear phases lined up: pre-assessment, vein optimization, precision insertion, and escalation protocols. Let's kick things off with phase 1, pre-assessment. Assess before you access. So this is your first crucial step when you walk up to that bedside. You've got to train yourself to resist the urge to just jump in and grab the first thing you see. Rule number 1 of great cannulation: look before you touch. It is a super common trap to simply zero in on the very first vein that catches your eye, usually right there in the antecubital fossa, the AC. But you know the AC is often a trap, right? It kinks the second the patient bends their arm. Instead, systematically inspect both arms completely. Start distally down at the hands and wrists and work your way up, preserving those proximal sites for later if you need them. Because the reality is, the best-looking vein at first glance is rarely the best vein for a lasting IV. And here's the thing, you should never, ever choose a vein just with your eyes. You absolutely must palpate. In fact, here's a fantastic pro tip for you. When you're palpating, literally look away or close your eyes for a second. Isolate your sense of touch. When you touch the skin, you're looking for very specific tactile feedback. A truly good vein feels soft, it feels springy, it rapidly refills right after you compress it, and crucially, it doesn't roll away from your finger. Your eyes can be completely tricked by a superficial, bright blue but super fragile vessel. Your fingers, though, they will always tell you the absolute truth about a vein's structural integrity. Moving right along to phase 2, vein optimization, maximizing vein potential. This is our limb preparation phase. Think of this as building the physiological foundation for success, way before a needle even comes close to the patient. You must fill those veins before you puncture. First up, properly apply your tourniquet 5 to 10 centimeters above your chosen site. Second, position the arm below heart level. Third, ask the patient to gently open and close their fist. And fourth, never forget this one, always verify hydration. Why? Because hydration physically plumps up the intravascular volume. When a patient is well hydrated, the actual physical target you're aiming for expands, making your job significantly easier. Never underestimate simple physics, guys. Gravity is arguably the cheapest, most underutilized tool in the entire hospital. By simply letting the patient's arm hang down freely below heart level for about 1 full minute, you let blood pool heavily in those distal veins. It is literally amazing to watch a flat, practically invisible vein suddenly pop up and become as plump as a water balloon just because you utilized gravity for 60 seconds. Now, if you've done all that and you still can't see or feel a good vein, it's time to bring the heat, 5 to 10 minutes. That is the exact time window required for a warm pack to be applied to the limb. Let's talk about the physiology here. Heat causes local vasodilation by physically relaxing the smooth muscle in the vein walls. But impatience is your worst enemy. Rushing it and ripping the pack off at 2 minutes, it just isn't going to cut it. You have to wait the full 5 to 10 minutes for that physiological dilation to really happen, and it will massively improve your chances of first-pass success. All right, let's transition into the actual physical mechanics. Phase 3, precision insertion techniques. Now that we've perfectly optimized the site, we focus on handling the needle. Before you even think about advancing, you must anchor the vein. You do this by firmly pulling the skin taut just below your intended insertion site. You want to pull down and away so you don't accidentally compress the exact vein you just spent all that time filling. This prevents vein movement, which is absolutely critical, right? Especially when treating elderly patients whose veins often feel like you're trying to pin down a wet noodle. If you don't anchor properly, that vein is going to slip right out of the way of your needle. Now, what's really interesting about this slide is how it highlights a very common clinical ego trap: choosing the right catheter. Look, we all want to be the hero who gets the massive 18 gauge in during an emergency. But trying to force a large bore cannula into a tiny vein, it's like trying to thread a garden hose through a drinking straw. It is a guaranteed way to blow the vein and rack up multiple failed attempts. A smaller 22 or 24 gauge catheter inserted perfectly on the very first try is infinitely better for your patient's immediate care than stubbornly trying to force an 18 gauge where it simply does not belong. Let's talk about the geometry of a successful stick. You want to use a nice, shallow insertion angle, specifically right around 10 to 20 degrees. To visualize that, it means your needle is almost completely parallel to the patient's skin. Going in too steep, well, that's basically a through-and-through assassination of the vein. You'll puncture straight through the top wall and blow immediately out the back wall. Keep your approach shallow, keep it slow, and keep it highly controlled. Okay, so you insert the needle and boom, there it is, flashback. But wait, stop right there. Do not immediately try to thread the catheter. This right here is the #1 reason IVs fail at the very last second. You must perform this crucial micro step. Advance the entire unit another 1 to 2 millimeters further into the vessel. Remember, the needle has a bevel, and the sharp metal tip extends past the plastic catheter. If only the metal tip is inside the vein and you try to push the plastic, you're just going to push the vein wall away. Advancing that extra millimeter ensures the plastic itself is safely inside the lumen before you thread it. We have to talk about what happens when things don't go as planned. Phase 4, escalation and failure management. Despite our absolute best efforts, things just don't always go right in medicine. We need a solid plan for when an attempt fails. If that vein blows, you need to execute your damage control protocol flawlessly. Step 1, stop immediately. Step 2, release the tourniquet so you stop the pressure that's actively pushing blood out of the vessel. Step 3, apply firm pressure to the site. This saves the area from blowing up into a massive hematoma, which would completely ruin the surrounding anatomy for any future attempts. And Step 4, move on and choose a completely different site. So the crucial point is this: once a vein is blown, it is blown. Do not give in to the temptation to keep fishing around in that same vein, hoping to somehow miraculously salvage it. Digging around with the needle is literally like blindly fishing in muddy water. From the patient's perspective, it is excruciatingly painful, it causes unnecessary tissue damage, and it totally shatters their trust in you as their clinician. Pull out, apply pressure, and reset. I want you to firmly anchor this number in your mind as a strict mental stop sign. 2 failed attempts. Historically, there was this culture in medicine where people would try 4 or 5 or even 6 times. Thankfully, that culture is changing. After you have missed twice, you must recognize that continuing to try blindly just isn't serving the patient. Stepping away after 2 attempts, that doesn't show failure, it actually shows maturity and excellent clinical judgment. When you hit that limit of 2, it is time to escalate, and escalate early, to ultrasound-guided IV access. Please don't wait until the patient is completely bruised and entirely out of viable anatomy. Ultrasound takes a blind anatomy guessing game and turns it into a highly precise visual procedure. It is rapidly becoming the gold standard for difficult vascular access, and knowing exactly when to ask for it is the hallmark of an outstanding clinician. As we wrap up this explainer, I really want to leave you with a massive mindset shift. Great cannulation isn't about luck, it's about technique. First pass success is a highly trainable skill. Going from a clinician who just hopes to get an IV to someone who knows they're going to get it all comes down to deeply respecting this exact process, inspecting carefully, filling those veins, warming them up, anchoring the skin, and advancing that final crucial millimeter. So take a close look at your current clinical habits. Which of these specific techniques that we covered today are you going to implement to guarantee first pass success on your very next shift? Take these tools, apply them immediately, and go empower yourself to tackle that next difficult stick with total, absolute confidence.